Welcome to our first session for Arogya Manthan, Roadmap for Universal Health Coverage in India. Requesting you all to settle down so we can begin the session in a timely manner. Welcome to our first session for Arogya Manthan, Roadmap for Universal Health Coverage in India. India is committed to achieving healthcare for all by 2030, which is fundamental to achieving other sustainable development goals as laid down by the United Nations. Universal health coverage ensures that people have access to quality health services, including prevention, promotion, treatment, rehabilitation, and palliation, without incurring financial hardship. We have a distinguished panel today of policymakers, researchers, and practitioners who would, through their discussions, cover and lay emphasis on the key elements of UHC and the challenges therein. Without further ado, it is my honor to welcome our distinguished panel today, led by Chairperson Ms. Shalini Prasad. Ma'am has over 37 years of administrative experience working at the national level with the Government of India and as well as the state, district, and grassroots level. She currently holds the post of Special Secretary, Health, Nutrition, and Women and Child Development at Niti Aayog. We welcome you, ma'am. Our first panelist for today is Shri Dilip Kumar Kotia, a member of the Indian Administrative Services from the 1981 batch, with over 48 years of work experience in various administrative positions. He is currently chairperson of the State Health Authority, Uttarakhand. We welcome you, sir. Next, I'd like to welcome to stage Shri Manoj Jalani, a member of the Indian Administrative Services, batch of 1987, with over 3 decades of experience in designing and implementing public policies and programs for social economic development, particularly in the health sector. He currently serves as the Director, Department of Health Systems at WHO, Southeast Asia. We welcome you, sir. We now call upon stage Shri Sampat Kumar, a member of the Indian Administrative Services, batch of 1997. He has 24 years leadership experience, including more than 17 years in the Indian Administrative Services and 7 years in the non-profit sector. He currently serves as Principal Secretary, Meghalaya. We welcome you, sir. I would like to now invite Dr. Sudhakar Shinde, a member of the Indian Revenue Services from the 2007 batch, who has served across various government departments in the state of Maharashtra. He's currently posted at State Health as CEO of State Health Agency in Maharashtra. We welcome you, sir. Last but not the least, I would like to welcome upon stage Dr. Jack Langenbrunner. He is a global health financing expert with over 35 years of experience advising governments on health systems reform. He's an independent consultant to the World Bank, where he serves as an expert advisor on health reforms to the Kingdom of Bahrain and an expert advisor on social health insurance to the Government of Indonesia. We welcome you, sir. Finally, I'd like to extend a warm welcome to our moderator for this panel, Dr. Nishant Jain, a thought leader in the field of health systems, health finance, and health insurance from the past 17 years. He has been an esteemed advisor to the NHA for the Ayushman Bharat PMJ scheme. He currently serves as a health specialist for Asian Development Bank in the Human and Social Development Division. We welcome you, sir. I'd like to now hand over the stage to Dr. Nishant Jain to open today's session.
Thank you, and very warm welcome to all the panelists and the chair, and I'm very happy that we are having this session because this topic is so important for not only the country but even for the world, because if India moves towards UHC, it has implication for everybody. So we have Mr. Shalini with us from Niti Aayog, and as the chair of the session, ma'am, may I request you to first give your opening remarks? Thank you.
Good morning. So I think this is really, as Dr. Jha pointed out, a very topical issue right now. And, whenever we're talking about basic quality of life, I think health comes very high on that. And when we're looking at where we've come, I mean, how far the country has come, it's interesting because finally we have really, I think we've moved quite a bit. And we've reached a point where health services, access to health services is no longer aspirational, but this is something that we are all looking upon as a basic service for the population. But of course, equally it becomes equally daunting given the population and the other challenges within the country. So we have seen a quantum jump, whether it's in the number of doctors, nurses, hospitals, clinics, and other services. So I think we've really reached a point where we've now no longer talking about incremental increase or incremental access to health services, but where we've really reached a point where we need to make that quantum jump to actually ensure universal health services. And I think this is where we are today in today's discussion. So the question, I mean, it's when we look at where we are and where we need to be, a lot of what we are looking at is proxy indicators. And we've been a lot of discussion on the missing middle, but before I come to that, I'd just like to once again sort of reiterate the point that the introduction was made at the introduction. That when we're looking at health services, we're looking at the whole range of health services, right from promotion, prevention, treatment, rehabilitation, and palliative care. I think this is a point that we need to keep reiterating because we often tend to focus more on treatment because that's where I think the bulk of the pressure really comes from. So when we're looking at the gaps, where we are and where we need to go for universal health coverage, I think once again we need to look at various factors. Now, whether it is, one is of course geographical, I think that needs to be ascertained, and I noticed that the Health Ministry recently released the National Health Accounts, and so when sorry, not the health account, okay, I'll come to that in a minute. I was talking about the NSSO report, and basically the persons who were reporting illnesses. Now, Kerala, the percentage was 24%, Assam, Bihar, it was less than 3%. I think that in itself focuses on the fact that regionally we can't really get away with it by looking at things strictly at a national level. Financial, of course, we'll come to in a minute. And the availability of infrastructure. Because we do have, we do talk about, for example, that we're almost there when it comes to doctor population ratio. But we do know that there are a lot of issues when we're calculating this, whether it's live registers, whether it's concentration in urban areas, whether it's specific to certain geographical areas. So basically, when we're looking at where we are, I think, and how to plug it, we need to look at it for each of these things. It's both geographical, but also for example, for promotion or prevention. And when we're looking at the determinants of health, I think that should actually form a very strong part of our whole discussion on universal health coverage. So now coming to the missing middle, which has been a hot topic of debate. So once again, we do talk about, how 30% or something like 40 crore people are currently outside the ambit of health insurance. That is not an exact figure, perhaps it's a good approximation. And we really then, what we end up doing is we do sometimes because of this miss out on things like people who tend to fall through the cracks, which is not only the missing middle, but out of the lot of the people who've been insured, how many of them actually get access to the healthcare, how many especially voluntary or those who are through things like the employers, like the ESIC, if they lose a job, they move a job. So there are various other factors. So this 30% perhaps we need to look upon really loosely. It's not, I think, just exactly So the issue I think really is that apart from just sheer coverage, whether it's coverage for the whole range of services, and we do see that the reimbursement, for example, I mean, that was slightly dated, I guess, but was about from insurance was about 7% from private insurance. Now that's a fairly low figure. So even if we've got a huge coverage in terms of enrollment, we really have to, I think, focus a lot on what are the services that are being given and upon the floating coverage. So I think really we need to look beyond the traditional way we have been looking at insurance and look at maybe perhaps safety nets, perhaps a slightly insurance plus, and also services. So I think this whole debate currently that is really a hot topic. It needs to be taken to its logical conclusion, and I think this is really, we are at the level where we can perhaps make that quantum jump to universal health coverage. So I'll be really looking forward to the debate today. Thank you.
Thank you. And thank you for setting out the issues so clearly. And as you rightly said, when we talk about universal health coverage, it's not only about numbers, because people often confuse that, so many people are covered, now we have reached UHC. And I think that is only one axis of cube of universal health coverage, which many people use. But what is being covered, and that's where I think in PMJ we are covering inpatient, but there are a lot of things which are not covered, especially primary care. And also another angle is that when you give an entitlement to people in terms of coverage, there has to be supply to match it. The hospitals, whether it's public or private, should be there. So the reform of supply side is also equally important, because otherwise you can just create demand but nobody is there to fulfill it. And all the successful countries which have done UHC reforms, they have not only done demand side reform, they have done both. And many times people miss that. So thanks, ma'am, for very nicely laying out this topic. So we have with us Mr. Dilip Kotia from Uttarakhand. Uttarakhand is a very interesting example where the state is trying to cover everybody in the state. They have taken a decision and covering it, and they have also covered the formal sector in terms of government employees and all. So with Mr. Kotia, I think he's there at the helm for many years, and I think he's the best person to tell us how Uttarakhand is doing and what are the challenges they are facing. So maybe we request you, sir, for your inputs, please. You have a presentation? Yes, please. So then, so we thought that maybe we'll have a couple of examples where we can get presentation from the state, and that's where I think we have requested Uttarakhand. So please, sir, thank you. Presentation. Somebody will put up the slide? Yes.
Good morning, everybody. Thank you, Chairperson Shalini, who has been my colleague in Uttar Pradesh cadre, Nishant Jain and other distinguished panelists. The experiment which has been done by Uttarakhand, or the beginning which has been made by Uttarakhand in the direction of universal health coverage, I would like to confine only to the practical aspects and implementation aspects. Since this is a very big subject, universal health coverage, as Shalini and Nishant have also mentioned, that mere numbers will not do. So that I will take up when we will come to the aspect of problems and challenges. So with this rider, that there is nothing expertise in this presentation. This is only what has been done by the Uttarakhand and how things have been taken up, so that we at least move forward in the direction of universal health coverage. Uttarakhand, as we all know, is a small state in Himalayan region, hill state, and out of total 13 districts, there are only 4 districts in the plain area, and rest of the state is hilly area, and the height reaches up to 20,000 feet. In fact, it has been created in 2000, and the population of Uttarakhand is slightly less than 1% of the population of the country. We have, say, in 2019, population of 1 crore 10 lakhs, which has certainly increased if we talk of date. So, in 2018, we had more than 1 crore population, and out of this, nearly 30 lakhs were already covered under various central government schemes. We know ESIC, CGHS and ECHS. And remaining 70 lakhs have been covered under the PMJ. Apart from the central government PMJ, state had its own schemes known as Ayushman Yojana. And for last 1.5 years, we are also having a separate state scheme for our state government employees and pensioners. So, if we say in general, 100% population of Uttarakhand has been covered either in one scheme or the other, and that is irrespective of income. It was a very conscious decision of the state government that health is the state responsibility, and income is no bar for availing advantage benefits of Government of India scheme as well as state scheme. Insofar as data bases are concerned, we have of course SCCC 2011 database which is being used for PMJ, but since SCCC PMJ had lower level section of the society, we have also used remaining SCCC database also, which we call as SCCC plus. So there were in all 19 lakhs families in whole SCCC data, and out of that 5.24 lakhs were covered under PMJ, but we have also used remaining 14 lakhs SCCC data which goes up to the richer or middle class people also. So whole SCCC database, and the most important database is NFSA ration card data. So nearly 23 lakhs families who were under this NFSA database all have been used for the purpose of running this scheme. We are running it in trust mode, and there is national portability, and for all purposes we are using NHA IT system. We are completed 4 years of PMJ, but soon after PMJ launching of PMJ, state government in December 2018 introduced its state scheme Atal Ayushman Uttarakhand Yojana, and after that scheme for the government employees and pensioners. We started in a very token manner in 2018. Then in 2019 onwards, we are presently having, say, nearly 50 lakhs Ayushman cards, and the number has been increasing year by year in a very fast manner. And though number of cards is 50 lakhs, but all 100% families have already been covered. So each and every family has at least one or more card of its family members. We have been continuously preparing cards, and since the scheme allows that if anybody falls sick, the card can be prepared immediately either by CSC or by the hospital, or for that matter even state health authority also directly helps in preparing the card of a sick person who for some reason though already covered in the family but could not get his or her individual card. We so far have provided benefits to the 5.24 lakhs families of SSCC, and in addition to that, as I mentioned earlier, 13 lakhs more beneficiaries have been added to it, so which means that nearly 2.5 times the PMJY target has already been covered by the state, and compared to other states, some other states are also have added additional families. So Uttarakhand is one of those states who has done, who have added to the PMJY a large number of beneficiaries. We have 225 hospitals empaneled, out of which 102 are government hospitals and remaining 123 are private hospitals. As I mentioned that it's a very different geographical peculiarity state. So we have our private hospitals are concentrated in only 4 districts in plain areas, and there is a acute shortage of private hospitals in hill districts. And there are many districts in which there is not even a single private hospital, which is clear from the next slide. The whole green portion shows about the government hospitals, and yellow color shows the existence of the private hospitals, except Dehradun, Haridwar and Udham Singh Nagar district. There is very small number of private hospitals in those districts. So this is a unique situation for Uttarakhand, that private hospitals' participation, because of their viability or profitability, or for their commercial concerns, they are till now they are hesitant to go to the hill districts and open hospitals there. Insofar as beneficiaries under the scheme are concerned, we started from say 20,000 or so, and now today the cumulative number is more than it's around 5.6 lakhs. So there is a very sharp increase in the number of beneficiaries, as number of cards also increased, and many people who were having money, say 5 lakhs rupees per year per family, so for their major ailments, they also came down and utilized the services of tertiary sector for their treatment. So the money which was required to be paid by them, or if they did not have money, they were without any treatment. So that thing has been taken care of, in spite of the fact that the number of hospitals in hill districts are very, very less. This shows that pre-authorization hospital admissions have been increasing continuously, and from 200 to 200 in 2018-19, we have come up to more than 650 patients hospital admissions every day. Insofar as ratio between private hospital and public hospital is concerned, nearly 1/3 patients are treated in government hospitals, and remaining 2/3 is the share of the private hospital. So still, government hospitals, though they are available in each and every part of the state, but due to various issues related to the infrastructure and doctors and other facilities, there is lot of scope. There is lot of scope for further strengthening of the government hospital. So, as we have started towards the USC, so in many parameters we are well ahead of the national average. This financial aspect is the most crucial aspect. If we see that from 8 crores to 250 crores in 2021-22 is the total expenditure. The expenditure of 2022-23 is only for five months. So it will reach around say 400 crores in 2020-23. So this financial aspect is an issue which I think is to be discussed here as to what will be the projection and how the funds will be arranged. We also have a state government health scheme which is cashless for government employees and pensioners. OPD is also covered, and every other additional facility has also been provided to the government employees and pensioners. It's on the CGHS pattern. Every rate and every facility is as per the CGHS provisions. We have done some experiment, and the most important experiment is that we tried to develop a system of audit in which all cases which were hospitalized or for which claims were submitted were quickly audited on daily basis, so that if there is any possibility of abuse or misuse, it can be detected immediately, and also it facilitated in claiming of process. And Uttarakhand has been very regular in making payment, and the turnaround time is around 7 days. After filing the claim, the payment is made even less than 7 days sometimes. So we have taken care of the abuse, misuse in a very special manner, and we have been fair to the hospitals not only for making their payment, but if they are not satisfied by any of our decision, they have a right to file a petition review request, and that is also seen by an independent committee, so that without any bias, their grievances of the hospitals are also taken care of. We have recently developed a sort of verification letter from beneficiary and a certificate from the hospital for abiding by the rules, like कि कोई पैसा चार्ज नहीं किया है, और जो डॉक्यूमेंट्स प्रोवाइड करने हैं, डिस्चार्ज समरी एंड अदर्स at the time of discharge, वो सब प्रोवाइड हुए हैं. This we take not only from the beneficiary but also from the hospital, and these two documents have been made part of the claim settlement, so that a sort of beneficiary empowerment on the one hand and accountability of the hospital on the other end also develops. There are many challenges which will be discussed by the experts also available here. There are problems related to databases, lot of overlapping is there, and as was mentioned earlier also, forward linkages and backward linkages now are to be taken care, especially in Uttarakhand, where we have already gone for USC, and private hospitals have to be encouraged in the hill districts. So we have suggested to the state government also to develop a scheme where industry-like incentives are also given to the hospital, so that they, for the hill areas, so that they open their hospitals there, and their capital cost is at least covered by various subsidies and incentives. The package rate has also become an issue, because when there is sort of universalization, so hospitals are facing difficulties in their profitability or viability aspect, because PMJ was initially developed keeping in view that hospitals will be getting additional beneficiaries, additional patients. But now in a state like Uttarakhand, so all patients are having Ayushman card, so there is no additional patient. So they sometimes present their case that there is case for further increase in the rates for at least those states who have already covered most of their population. We strongly feel that now time has come when, rather than SCCC, NFSA database should be adopted in the country. The SCCC database is not quite old, but also has very many inaccuracies. So now NFSA database, which will also increase the coverage, though it will have its own financial implications. But I think after 4 years, we should seriously deliberate on it, that a good database with some additional funding is the need of the hour. And I think after 4 years, we should also think that why should there be need for so many schemes, even by the government of India. So ESI, ECHS and CGHS should be merged, should be made one scheme, not only under the umbrella of Ayushman scheme, but on the same pattern on which PMJ is being run. And there are quality issues also, we all know it. And of course, now there will be need, if Uttarakhand has covered most of its population for IPD, so that some other aspects, prevention and then OPD and post-health care should also be thought and be made a part of the Ayushman scheme as such. So this is in brief, but I would be ready to answer any questions if many things have been presented in a very brief manner. Thank you very much.
Thank you, Mr. Kotia, and I think this was an excellent presentation to see actually how Uttarakhand has progressed from 2018, when PMJ started at a much smaller scale, to universal coverage now in terms of the population. So I think this is, and in spite of being a hilly state where supply side is a challenge, state has been able to do that. So what we'll do, that we'll have state experiences first, and then we'll come to the larger issues. So we have Sampat Kumar with us, who is representing state of Meghalaya. Meghalaya is also very interesting because this was one of the first state which tries to universalize health insurance long back. When even PMJ was not there, RSPY was there. And in PMJY, they tried to further strengthen. And they also have an issue of availability of private healthcare providers, because that's a big challenge there. And I'm very happy that Sampat Kumar is here to share, because he has a unique advantage that is also Secretary Women and Child and Secretary Rural Development, addition to being Secretary Health. So he can do a lot of things of convergence and coordination in the state, which many other states find it difficult to do. So please, over to you. Thank you.
Thank you. Thank you, Nishanji. So, very good afternoon to all of you. I pay my respects to Madam Shalini, who is chairing this panel, and also to all the distinguished panelists and the distinguished colleagues from different states who are present here. So, we would like to share a few experiences and experiments that we are making in Meghalaya. So, this is in the state of Meghalaya, we have been using an interesting concept, I think. That's why I would like to introduce here a state capability enhancement in a model especially to build the state capability, by solving critical development challenges in Meghalaya. It's not only Meghalaya, it's essentially, it's a kind of the states do have a lot of challenges. Coming back to Meghalaya, Meghalaya is one state where we have different challenges, and so what we started actually, when we started, looking at the challenges, initially, when we looked at mostly, we started with the technical challenges, saying that, there is a deficient health infrastructure, and we started actually, this is the way, the state has been investing a lot, over a period of time. So thinking that by building PHCs and CSCs and the hospitals, we'll be able to solve the problem. But like again, we have a problem of trained human resources. And very important thing is that Meghalaya also has a very unique geographical challenges. So like if you ask me, there was one of the important points for safe delivery. Within 30 minutes, we should have a place where actually we can take a pregnant woman when she actually started, experiencing labor pains. But a majority of our state is just impossible to reach out in the 30-minute span to a hospital for a safe delivery. So then we also have these default explanations, like, we always say that there is a hesitancy, there is a low levels of health demand. These were the technical challenges. So what we started was that, we used an approach, I call it a problem-driven iterative adaptation approach. It's something that we use this approach during this COVID period, and COVID period was a kind of a blessing for the state in a way to understand the deep causes of the health systems and health issues. So when we started doing this, we found more adaptive challenges. So like we found, like Meghalaya, everyone says that it's a matrilineal society, and whereas we didn't find that agency, women's agency. There was a very low birth spacing, resulting into high maternal mortality. When we did this analysis, we found quite a 87% of the maternal deaths what we have audited, there was no spacing. The spacing that is required, at least 1,000 days spacing, that there was no spacing. So there is there is a teenage pregnancy issues. Even the maternal deaths, again, a large percentage, about almost like a 17% contribute to the teenage pregnant women, who succumb to, these are some of the gender issues, and then there's a poverty and low trust on the systems, and then we also found, then based on this, we brought a state health policy. I will explain in the next slide what is that state health policy. And then but again, but the policy is not enough, because again, we require to implement the policy. We require a kind of a lot of focus should be given on the implementation. So that's where we designed this state capability enhancement framework, which I would share. So this is something that we found there's a lack of sense of purpose in our systems, poor coordination among functionaries. So this we brought the state capability approach, to bring clarity of purpose at all levels, including political level, and using this iterative approach for problem solving, and also using the data and feedback loops for learning and collaboration between the different departments and across hierarchies. So this while this is while doing this, actually, this is a kind of one thing I would like to share is a 3D healthcare model for achieving universal health coverage. This is it's a kind of a guiding framework. What we are talking about is that, we often actually, in fact, including, in fact, our respected CEO sir is here. I think when he came to Shillong, we were sharing the same thing. We were more like a sick care, not very provocative statement, not health care, because when people get sick, then we started actually working on them. So can we actually change that entire paradigm? So that's where a lot of focus I think we definitely require to give on the preventive care part of it, so especially addressing both the demand and supply side interventions. So here we need a lot of course, health and wellness centers and, early diagnosis using some smart technologies that what we have, artificial intelligence based. And a lot of, we are also trying to redesign this entire primary healthcare, comprehensive primary healthcare, because still when we have had one of the sessions with all the medical officers, looking after the primary healthcare centers and community healthcare centers, we asked about what is that, whom you are covering. Mostly they are covering those people who are coming to the hospital. They are not covering to those who are not coming to the hospital. How actually we can reach out to each and every one. How actually we can do a kind of a Costa Rica kind of a model where, every year, every person, is screened at least thrice if the person is a senior citizen, and if the person is a comorbid condition, so twice, and every citizen is screened for at least once. So how actually we can bring that kind of a comprehensive primary health care. And then, of course, curative is important. Here actually we have this health insurance schemes and, and strengthening the primary and secondary and tertiary care. Here also what we have been doing is that we found we have almost 177 specialists vacant, and out of 30 community health centers, only one community health center is FRU, first referral unit, because we don't have specialists there. So we also have, recently we have signed an MOU with the government of Tamil Nadu to send our doctors and see that like the 6 months EMOC and LSAS and, sonology training can be done. So there's again a curative part, how actually we can strengthen that one. Then enabling part is a very policy and measures, how actually here we found we brought elected health local bodies in the state. So we have now the village health councils, which are elected bodies, and they are currently, the elections are going on, and this is something that is an interesting thing. And then we putting a lot of gender equality. We brought a women's reservation in the village rural bodies to see that how actually their role and participation would increase in terms of creating that agency. And we also have a social audit law in the state, which actually which in fact does the audit and gives the power to the people to see how these programs are implemented, how they can access their rights and entitlements. So that also we have brought it, it covers about 21 different programs of the state. And we also, interesting thing is like a ECD. We found this is something that is a very, it can be a game changer. We found early childhood development. There's a lot of research is happening. We wanted to, utilize that research, science of early childhood development. So we launched again an ECD mission. So this is and the other is like a CMSMS is a Chief Minister. I will tell about that one in the next slides. So I just wanted to take this very quickly. As per the WHO definition, as we see, universal healthcare means all individuals and communities receive health services they need without suffering financial hardship. It includes the full spectrum of essential and quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. So here actually we are trying to do a small way to translate these principles into practice. First thing that, as I mentioned, how actually we are trying to cover all the individuals and communities. So there is in fact, one of the things that what we have been doing is this comprehensive primary health care. And idea is that how actually we can make as I mentioned just now, like how actually we can reach out to the people, and how actually we can proactively reach out to the people who are not visiting the health facilities, and see that they are screened and they are provided proper health care and guidance. So that's one that requires a lot of sense of purpose and a lot of mission approach. We call it like a mission government workforce we require for that. So we are working on that one. And then we also, as I said, we have just started an experiment using that positive population healthcare management, which is essentially leveraging this digital technology and AI. And of course, full spectrum of services involving these village health councils, to ensure that, there is a full participation, and across the life course, ECD mission, as I've just mentioned, and financial hardship Meghalaya health insurance scheme, which has been brought, in fact, in collaboration, and we are, PMJ, Prime Minister's Jan Arogya Yojana. Here we are providing universal health coverage in the state, in the sense in addition to the SECC beneficiaries, all other families are covered in the state. So this is another thing. And we also have this Chief Minister's Safe Motherhood scheme. As I mentioned, the real challenge for our state is the geographical challenges, and and a lot of, because we have 85% is indigenous population, so a lot of heuristics behavior, and how to actually really engage with them. So a lot of investment is required. They trust traditional birth attendants more than the health systems, how actually we can really co-opt those systems. So bringing that, we created again a Chief Minister's Safe Motherhood scheme over and above the National Health Mission has been initiated. So this is a small a slide about each of those things. I would like to present it to you. This is a very interesting thing. This is we have been working with we have a for initiating, especially leveraging this digital technology. We have a smart village movement project, where we are working with UC Berkeley, and where we were doing this, essentially how we can create a model where by leveraging this mobile applications, how actually we can promote a better healthcare in terms of identifying, especially preventing those things at the early stage. So again, it requires a lot of community mobilization. So it's basically data plus community mobilization model. So it's like a more you require. We have the data, we have digital. So how, if you can actually, bring them together, how actually we can do. So we are doing this exercise, and we have identified about 40 parameters locally relevant, and creating this work, and and this is from sensitization to the health screening to investigation to intervention to prevention strategies. So it's a pilot stage. We're also trying to produce some study, and then we'll share it with everyone. Then the Village Health Council, as I mentioned, I think this is something very, in fact, our CEO, R.S. Sharma sir, actually, he was there in Shillong, in fact, telling about this important thing, because health cannot be delegated. Health is something that everyone has to take responsibility. Everything can be delegated, something can be delegated, but not the health care. So how that, to bring that sense of participation, we've brought this thing, and it's giving us some very interesting, initial, quick wins for us, because the participation of the people, and how actually they are trying to save the lives of the mothers who are high-risk pregnant mothers in the interior places. A very interesting thing work is going on, but it's essential. It also provides a lot of it solves the demand side problem of the healthcare. We could see that one. So though we have these committees are there, but elected bodies have always a greater role. And here we also brought the women self-help groups very actively in this village health councils. The village organization president is the co-chairperson of this village health council. So then the ECD mission, as I mentioned, I think you all aware, like if you invest ₹1 or $1 in early childhood development, you would get 16 times the benefit, cost benefit analysis. This has been proven. There is a Nobel Economics Prize was won on this particular research, and we have to really, this is something that we wanted to really do, because we have actually in our country, we have all the programs are there, but only thing is that really prioritizing and bringing that focus, and so that's what we are doing now. And in fact, we are working with ADB and and also on this particular idea. So where the idea is that if you this is a demographic dividend to really create. If you invest, the data shows that if you really provide that caregiving support, and especially not only that just nutrition, but also like especially the enabling environment, the socio-emotional support at the children and we are just trying to transform this Anganwadi centers as early childhood development centers. So this actually will give us, we are hoping that we can actually achieve a cognitive capital in future. The children who pass through this particular schools, like the way Tamil Nadu children who pass through the midday meal school, how actually they did differently at later point of a time. I think this is something that one thing we are really looking at it is again this we are also trying to create some kind of a test kind of a thing to share with the rest of the the states. So then I mentioned about Meghalaya Health Insurance, and this is essentially we put an OPD package because our to provide the antenatal care, because at least people can go to the private hospitals wherever we have the proper facilities are there for antenatal care. So we also put this OPD package, and then this I mentioned about Chief Minister's Safe Motherhood scheme. We have now we have a data that shows that entire, as I mentioned earlier, we have a mother app where actually we have the data of all the pregnant mothers. We also know their status, who are actually high-risk pregnant mothers, whose expected date of delivery is in the next 14 days. And then, we actually try to bring them much before the so that we can save the mothers. And so a lot of the focus is there. Here also we brought how to actually integrate traditional birth attendants so that into the health system. So we're trying to find local solutions for the local problems. This is one of those state capability framework that what we have been saying is that we definitely require, and also providing that sensitive support that is required to build the trust. So the data is interesting data that we could see with the results of the entire approach of the systems approach. We can see there is the maternal deaths. Actually, we could see some a kind of a reduction, and also we could see that there is a sense of purpose among the entire workforce. Whether it's a medical officer, as a block development officer, whether it's a DM or DC, this is the most priority for us in the state. So this is these are some trends. But like this, I just wanted to end up with we are using this kind of a framework, as I mentioned, especially promoting this local leadership through problem solving. That's like an iterative approach. We have this weekly check-ins and we do this. And then building that citizen state responsive systems, like creating those community institutions, social audit mechanisms, that kind of a thing, and effective use of research and data, what I just mentioned, and also the, creating that sense of agency, not only just accountability, especially the government workforce is a huge latent potential is there. So we are trying to how to convert that latent potential available within the government workforce, who are generally not very accountable, but how to convert that into a kind of a mission-driven workforce. So that's the one area that where we are working, and then of course identifying this, addressing systemic challenges like gender barriers and the poverty and other socio-economic determinants of health, and finally political supportability. It's very important. Our state, is number 4 in terms of the healthcare expenditure. So our chief minister and our ministers and they're very passionate about this, and they're also measuring their success through this indicator. So generating that political supportability in all these interventions is also very important for for bringing that sustainable change, especially when we talk about providing universal health coverage, and providing universal health coverage means creating life. Creating life. I would say currently our life expectancy is around 70 years, and Costa Rica life expectancy is about 81 years. So even if we create a 10 years, it's about 1.3 billion people we have. So 13 billion life years can be created. So with this small quote from Ellen Johnson, so the former Liberian president, I would like to end my presentation. Thank you.
Thank you. Thank you, Mr. Sampat, for this large, very nice overview, taking a broader approach and talking about an integrative approach of what Meghalaya is doing in trying to move towards UHC. And I think this is a very novel approach, and I think a lot of things are very interesting. And I'm sure we'll be interested to know more. So now we have Sudhakar with us from Maharashtra, and he's one of the most passionate person I know working on the topic on which he's working right now. And he's there managing the scheme since many years. And PMJY came later, but the state scheme which was there earlier, he is handling that, and then now the PMJ. And this is something which I feel that he has very interesting ideas which he has executed in the state, and also he has some things which he finds still challenging, I'm sure. So I request Sudhakar to share Maharashtra experience, especially with respect to how PMJY and state schemes are working together, what are the challenges, and also how you're working to improve quality, reduce frauds and abuse, these kind of things. So please.
Good afternoon, everyone. Maharashtra is having its own flagship health insurance scheme since 2012. It was initially launched for 8 districts as a pilot, and in 2013 it was covering all the districts of Maharashtra. The name of the scheme is Mahatma Jyotiba Phule Jan Arogya Yojana. When Government of India launched Ayushman Bharat Pradhan Jan Arogya Yojana, then we had tasked to integrate these schemes. Under the guidance of my Additional Chief Secretary, Dr. Pradeep Vyas sir, who is here, we seamlessly integrated these two schemes. We had around 996 packages in our scheme, and Ayushman Bharat had around 209 packages. So we mapped all these packages. As far as the beneficiaries are concerned, in our state scheme, 2.25 crore families are already covered. For the COVID period, remaining 25-30 lakh families which are having white ration card, they were also covered. Now we have again sent proposal to government to universalize the state scheme to all its citizens, and our scheme is based on ration card. So our scheme will be covering all the citizens of Maharashtra who are having different type of ration cards. So we integrated these schemes by mapping these packages. Our scheme provides, state scheme provides coverage of 1.5 lakh per family per year. And those beneficiaries who are also beneficiaries of Ayushman Bharat, we extended this cover to them by another 3.5 lakh rupees to make it to 5 lakh rupees. We floated the tender with 1.5 lakh rupees as the insurance company's responsibility, and remaining responsibility for Ayushman Bharat beneficiary was taken by us. So our scheme runs on hybrid mode, and the same hospitals which are empaneled for Mahatma Phule Yojana are serving for Ayushman Bharat beneficiaries. So this is how we integrated these schemes. As far as the problems in terms of abuse, in terms of frauds are concerned, it is an ongoing process. Out of 1,000 empaneled hospitals in Maharashtra, I have personally visited more than 750 hospitals. Other 250 odd hospitals are government hospitals, and we don't visit them so frequently because we assume that in government hospitals they are following the best practices, although there is a scope of improvement. So in last, I am managing this scheme for more than 4 years, and there have been different types of permutation and combinations of fraud and abuse that can be done, and we have improved our system. We have de-empaneled more than 500 hospitals, and none of them has been re-empaneled for at least 3 years. We have recovered more than 12-13 crores from these hospitals and refunded this money back to the patients. Some were additional money collection, some were denial of the packages. If there was denial of packages, the entire money was refunded. So this is like cat and mouse. We find something, the hospitals will find another mechanism to do another kind of thing. But still, it's an ongoing process. We have national audit, national NAFU and SAFU. These two centers were, these two units work in tandem. and we have getting good inputs from NHA in terms of triggers for various frauds, various abuses. We investigate them. Most of them give us a very realistic and very thorough idea of what is happening at the hospital levels, and we find something very interesting and we take action upon. So this is something as far as the quality of healthcare is concerned, provided through our scheme. We have 3-4 mechanisms where we get proper feedback from the patients. We provide SMS, trigger SMS to patient at various stages. We write a letter to each beneficiary when they are discharged from the hospital under the sign of Honorable Chief Minister, sir. This letter has attached pre-printed inland letter form where they have to give feedback about the kind of services, kind of their experience, any complaint they have. These are 2 mechanisms. Apart from these 2 mechanisms, we have also pre-recorded Honorable CM sir's 1-minute message. When the patients are approved for their pre-auth, this message is run through our call center on their mobile numbers, which numbers are registered with us. This message talks about all the benefits. This message talks about what is free in the scheme. This message talks about if there has been some money collection, they can approach us on particular toll-free number and get their grievances registered. 4th mechanism is that to 100% patients, after 2 weeks of discharge, we make outbound calls from our call center. We have state-of-the-art call center with around 60 seats. And now we are in the process of increasing these seats. And every patient's feedback is taken. We analyze those feedbacks. Interestingly, patients are not forthcoming for the grievances when they are in the hospital because their near and dear ones are being treated and their lives are in the hands of hospital. They are not forthcoming for the complaints. But when we approach them through the letters and when we approach them through call centers, we get quite a lot of complaints. We register them and we try to improve our system so that such kind of grievances are not happening in the future. So these are a couple of things that we are doing. We are expecting that government will increase this cover to remaining beneficiaries of the state as well, and we will become one of the first states which will provide free healthcare insurance scheme for more than 13 crore beneficiaries of the state. These are the broad contours that how we are managing our scheme. Last week, Nishant was in my office and we had discussion about the universalization of healthcare scheme. I am a medical doctor and that got into civil services and been working in managing this scheme for more than 4 years and had an opportunity to take part in other activities of public health department. I was part of the COVID response team of the state. I am of the firm opinion that government needs to have a look at solutions to provide health insurance scheme. We should have our public healthcare infrastructure as the mainstay of our universal coverage of the health mission, and such kind of health insurance schemes can be an add-on and can be a stopgap arrangement to address the gap between the disease burden of the community and government healthcare infrastructure. I am aware that government healthcare infrastructure is not up to the mark. Somewhere we need to sit, we need to analyze the gap for various states. Different states are at different level of healthcare infrastructure development. We need to find these gaps and we need to find the solutions for these gaps in 2 ways. First, immediately, we need to pitch in our private healthcare providers, make a public-private partnership through these kind of schemes, and we need to have a very solid time-bound roadmap to bring the public health infrastructure to that level. Just to tell an example about the financial burden of such schemes, when our scheme was launched in 2012, our premium was 333 rupees. Today I am paying premium of around 800 rupees, and my next tender is due in March 2023, and I am expecting premium of not less than 1200 rupees. So my expenditure for earlier year was 300 rupees and now it is going to be 400 rupees. So 4 times financial burden is increased in last 10 years. Moreover, when we call it a universal scheme and I have only 1000 hospitals empaneled, so there is a restriction of number of hospitals being empaneled in the scheme. If you remove this restriction, my premium is going to be increased by at least another 500-600 rupees. So you imagine 2,000 rupees premium for 2.5 crore families in the state, and this is going to be an incurring cost for every year for the government. Today, if I sit and analyze the total number of secondary and tertiary procedures happening in the state of Maharashtra, they are somewhere between 25 to 30 lakh. And my scheme is providing not more than 6 lakh secondary and tertiary packages. So there is gap of coverage in terms of beneficiaries, gap of coverage in terms of services rendered by private healthcare providers. So we'll have to sit and analyze whether we are going to have such kind of money to fund universal health coverage. Another example, I was working under guidance of my additional chief secretary as a part of COVID response team. I was the one who conceptualized and formalized rate capping for private healthcare providers in the country. First time we implemented it, and we successfully implemented it. The experience of monitoring, regulating, I was competent authority to take the actions against them for the state. The experience has been horrible. We cannot control, we cannot regulate private healthcare provider in terms of providing rate regulations, as well as we cannot fix each and every kind of additional out-of-pocket expenditure through such kind of schemes. I have visited 750 hospitals, de-empaneled 500 hospitals, but still fraud continues, still abuse continues, still money collection continues. The whole purpose of this scheme is to avoid, to reduce, to give away with the catastrophic out-of-pocket expenditures, but somewhere I feel that it is not going to meet 100% or to the level it is happening in the public health infrastructure. I proudly say that in my department, in public health department, there is not a single penny incurred by a beneficiary when he or she is undergoing secondary or tertiary care treatment. But that is not the case in the insurance arrangement with the private healthcare providers. As far as COVID concerned, Maharashtra has diagnosed around 80 lakh, detected 80 lakh COVID positive patients. Out of them, 20% patients were admitted in the hospital. Out of these 20 lakh patients, 14 lakh patients were treated by public healthcare infrastructure. 2 lakh people were treated by private healthcare providers. I got data from IRDA, how much money was spent on these people through insurance scheme. 1 lakh people had their insurance cover, and various insurance companies has paid 10,000 crore rupees to the hospital for these 1 lakh beneficiaries. And our public healthcare infrastructure treated around 13-14 lakh beneficiaries, and that too at the cost of 5,000 rupees. So financial requirement to shift to such kind of schemes and attract all private healthcare providers and match their rates is going to have a huge burden on the healthcare scheme. We need to plan these schemes, we need to understand the gap, we need to have a solid time-bound mechanism to upgrade our healthcare infrastructure, and meanwhile we should depend on the insurance companies for healthcare providers, especially private healthcare providers. Another thing, I am of the opinion that empaneling government hospitals in public funded health insurance schemes is not a very value-adding proposition. If we have to fund these institutions, we should directly fund them, making public healthcare infrastructure to enroll patients under scheme, submit their claims, process their queries, have an entire team to get this money, and ultimately this money is routed through insurance company. So in my opinion, this is very cumbersome, and there is very inefficient way of funding public healthcare infrastructure, because at the end of the day 20-30% money is going to be kept by the insurance company, and our public health infrastructure manpower is already so much busy with clinical work, so they should not be saddled with this kind of additional technical work. So these may add to our numbers, but ultimately we are not giving any incremental service to the beneficiaries, because they are already getting free treatment in public healthcare infrastructure. So these are my couple of inputs, my learnings in my last 4 years of the scheme. I think I have been able to make my point very clear, and I hope these these points will be helping us to shape our policies in better manner. Thank you so much. Jai Hind, Jai Maharashtra.
Thank you, Sudhakar. And I think, as I said, he's very passionate about what he does. And Dr. Vyas is there. He will agree with me that Maharashtra, and irrespective of what he said, Maharashtra is doing excellent in implementation of the scheme. Of course, there are these challenges which he talked about. There are these larger issues in terms of designing of these health insurance scheme, in terms of the provision of the health insurance scheme, which needs a lot of discussion, introspection, based on also our experience of past 4 or 5 years of PMJ and before our other schemes. So there are a lot of areas to think, and thanks for raising many of these points. So now I'm very happy that we have Mr. Manoj Jilani with us, and we are lucky that he's able to come here today. He has spent a lot of time in health ministry, and still he's working on health only with World Health Organization. So Mr. Jilani, I know that you have a lot of thoughts, and we'll be very happy to hear them, and your wish.
Thanks, distinguished chair and distinguished panelists, and all the distinguished audience. It's my pleasure to be here amongst you on this very important panel discussion on moving towards universal health coverage. Sampat provided the definition on UHC in terms of all people and communities being able to have the health services they need without suffering financial hardship. And it includes prevention and health promotion and curative services and rehabilitative and palliative care services. Few things I'd like to upfront state in this gathering. One is that we should not equate universal health insurance with universal health coverage. And I think WHO keeps on emphasizing this part. Look at the definition. Don't think that universal health insurance should equal to UHC for a variety of reasons. Now, let's look in terms of India, India's situation. So India has very high out-of-pocket spending. I think it's around 50% or so as per the current national health accounts. We have pretty high catastrophic healthcare spending. In terms of how we measure progress towards universal health coverage, I'm sure most of you are familiar. So you look at, so under SDG 3, you have 3.8 concerning universal health coverage. And within that, you have two key indicators, one relating to service coverage and another relating to financial protection. Financial protection is in relation to, if more than 10% of the household expenditure is on healthcare expenditure, then it's treated as catastrophic. And India had, as per the last survey, around 17% was, and this is pretty high. And then we also looked at the breakup of the out-of-pocket expenditure. It's largely on the medicines, partly on diagnostics. So when you think in terms of what should be the way forward for universal health coverage for India, and what we also notice is in terms of global evidence that if you enhance public spending on health, it leads to reduction in out-of-pocket spending. It also strengthens public health facilities and supports regulation by competition. And with increased financial protection, the utilization of the services also is enhanced. So if you are addressing 3.8.2 in terms of financial protection, the health coverage also tends to be benefited. So the first thing that obviously we need to do is to enhance public spending on health. Okay, and what we are noticing now is that there is, through schemes like PMJAY, where there's an assurance, the expenditures are rising in states that are promised, like Uttarakhand and Maharashtra. We saw very fast rising expenditure for curative services under PMJAY. So the first thing, of course, we've been increasing our, but still around 1.3%. As per our national health policy, we thought we'll reach around 2.5% by 2025. At this rate, we are not likely to touch 2025. Now, I do understand that a lot of people are thinking that at times of fiscal stress, countries are experiencing fiscal stress. There's been a downward trend on the economy. There was a slowdown, and now the economy is picking up. We had to borrow. We had to incur huge borrowings, and now we have to repay the loans. There's a huge fiscal deficit. So at a time like this, asking more money for health does not gel well with the current economic trend. But I think essentially for that reason, that you faced once-in-a-century crisis because of health, because our health systems were weak. And it's important that this once-in-a-century crisis is converted into a once-in-a-century opportunity to invest in health systems, to invest in resilient health systems. And so it's not only in terms of advancing or accelerating progress towards UHC, but also in terms of advancing health security and health system resilience, which in turn would translate to economic resilience. So investing in health, and particularly investing, I'm coming to the next part of where to invest in terms of investing in comprehensive integrated primary health care, is what is going to be critical to not only advance universal health coverage, but also to advance health resilience and health security. Now, comprehensive primary health coverage, we came out with the Ayushman Bharat scheme. We promised to move about 150,000 health and wellness centers to provide comprehensive and integrated primary health care. And the other pillar is PMJY for providing curative services in secondary tertiary care hospitals. Now, we really need to invest big time, strengthen and operationalize the health and wellness centers in a manner that they were envisaged to be operationalized in terms of comprehensive package of services. There are 12 package of services, and they were also to be, you had to have an integrated care across different levels of care. So if you had NCDs and you had a hypertension, then there was a mechanism with clear referral pathways that they would go up to a physician at a secondary care facility, and the physician will then will advise treatment, and that treatment follow-up will happen then at the health and wellness centers. There was supposed to be teleconsultation mechanism. There was expected to be free essential medicines and free essential diagnostic services being available, robust health information systems, etc. So we really need to invest in comprehensive primary health care, strengthen our health and wellness centers and operationalize them. And within that, I think there are few areas that need to be addressed. One would be in terms of design of our provider team incentives to the team of providers. One good lesson that one could take from PMJY, which has really created a good IT architecture of providing payments to the health facilities within a very short span of time once the cases were approved. Now, when I was looking at, in case of Uttarakhand and in a case of Tertiary, where almost 100% is public sector, okay. So what's really happening is that now the money is flowing to the public health facilities. Prior to this, we still expect public facilities to provide free care. That was probably not happening for a variety of reasons, but now what's happening is that through this PMJY mechanism, in theory, you will have only public health facilities which are essentially providing the care under PMJY, but the money is flowing through this architecture and becomes responsive. So depending on the number of cases being served by a district hospital or sub-district hospital or a CHC, the money is flowing, is responsive. The health care facility providers have the necessary money and they are able to ensure free and cashless care to the patients who are coming to the public health facility. So what really has changed, not that earlier also patients were going to public health facilities, they were supposed to get free care, probably they were not getting free care, but now this money is flowing through an IT system and the money becomes responsive. We could probably do a similar thing and use the same architecture to transfer money. Now, don't get into specific cases, but simply to our health and wellness centers or PHCs based on the number of cases, and the responsive money flows to the facility so that they have the resources available with them to make sure that essential medicines, essential diagnostics, essential services, etc. are available, and people genuinely do not face any out-of-pocket expenditure. And our experience shows that when you have able to ensure in public health facilities access to essential, free essential medicines and essential diagnostics, the footfalls tend to go up, and the services overall would improve. In terms of the other aspect I emphasized was that close to about 80% plus out-of-pocket expenditure is on medicines and diagnostics. So one key area, we started with the free drugs and free diagnostics initiatives. We need to make sure that they are really implemented well. And when I'm saying implemented well, what needs to be ensured, I mean, whether it's PMJY or whether it's a CPHC or a short package of services, is what is the kind of your grievance redressal system that we have, which would ensure that the services that are assured are indeed assured, they're indeed guaranteed, available, and in case of denial, there are mechanisms for their redressal. One would be very happy if the state governments, in turn, put this in their, a lot of state governments have come with their State Government Service Act. So within the Service Act, if you could include JSSK or essential drugs or essential diagnostics, or some of the services that we are planning to provide under CPHC of Health and Wellness Center, that would then put pressure to make sure that those services indeed are available, that we promise or we expect the public sector to indeed provide. There's an issue about how to capture missing middle. I mean, that's an important area. We need to make sure that we capture the missing middle, and one needs to look at really creative solutions. I mean, of course, one way is where the state governments have stepped in and they are putting in money, but of course, you're also seeing very high rising costs and difficulty in sustaining, both in Uttarakhand and what I heard from Maharashtra. Can we think of more innovative ways of capturing? I mean, there are some states which have not done that. So how to, without adverse selection, can we convert this out-of-pocket expenditures on prepayments and get them, I mean, one will have to have brainstorming, but I'm sure we could find ways where without the threat of adverse selection, we could try to rope in the missing middle. In terms of, I think there is a value in terms of engaging with the private sector. We have many states where private sector is a huge player, so we just can't ignore it. It is there, at least in the short and medium term. We need to engage with the private sector and try to make sure that we try to optimize and use them for their strengths, and they complement public sector for public goods, for social good, and not aligned to the profit motive. Other couple of areas are in the areas of quality. I think both at the outpatient care, I mean, in the primary care, there are issues around quality. There are issues around quality in hospital-based settings, and this is putting a huge disease burden, plus also a huge cost to the economy. And I think that really needs to be enhanced. There is enough anecdotal as well as documented evidence. And lastly, I think we need to have good, robust health information systems, including regular surveys. I've been wanting to know the impact of Ayushman Bharat, and till now we've not been able to see the impact of Ayushman Bharat on reduction of out-of-pocket expenditure because we have not had a survey after that. So we need to have more frequent surveys and more robust health information systems to keep on helping us do the course correction. So that we make sure that we are on right track and the schemes that we have designed are indeed achieving what they were intended to achieve. So this is, if you would want, I mean, there were a couple of other issues around effective linkages between the two pillars. And I would think that, if you can have very clear referral pathways for different range of services, I mean, for both upward referrals and follow-up services at the lower facilities. And this can really be enabled through the ABDM, Ayushman Bharat Digital Health Mission. And I think that really has the potential to facilitate and enable this integrated care across different facilities, across from public sector to private sector, from public sector to higher public sector, etc. And through the ABHA, one really could do that. Within this, I would just think that, we heard about collecting feedback from patients who had been discharged and all that. I sometimes take these Uber services and sometimes Urban Clap for haircut and all. And I noticed that, one, the feedback provision is very, very simple. So every time I take the next Uber, there'll always be a question, and it's a simple click in terms of satisfaction. And there is, of course, provision to go deeper into it. And I think what we could do both for PMJY or even for CPHC visits, etc., you have the ABA number, in terms of gathering feedback and also out-of-pocket spending. So rather than, taking a next step of follow-up through phones and all that, every person automatically receives this message in terms of their experience, and if they had to incur any out-of-pocket spending, that would, of course, be very useful. It can be integrated and needs to be extremely simple so that people don't waste too much time, more than 5 to 10 seconds, on providing that feedback. But that could then provide in terms of rating of hospitals. So when you are wanting to link to a higher facility, the patient and the doctor could look at higher facility rating, grading, their experience, out-of-pocket expenditure, and utilizing not-for-profit sector, particularly for primary healthcare, would really be very critical. Thank you so much. I'll close here. Thank you so much.
Thank you, Mr. Janani. And as always, you gave some very interesting, thought-provoking ideas. And, this whole idea of financing reform in health wellness center, that was something which I think is also something which should be discussed more, not only service delivery, because the way you pay the money is another very important area. And how do we collect feedback in a much simpler manner and utilize it maybe for policy input decisions? These kind of things I think would be very useful. Sure. So thank you, Mr. Janani, for that. Now we have Jack with us. Jack is a global expert on a lot of topics, and I have known Jack since more than a decade, and he's an excellent resource. I'm very happy that he's here. He has worked all across the world, right from World Bank to OSAID to BMJF to so many organizations. He has written several books, so on a lot of topics, including provider payment mechanism and all. So on universal health coverage, Jack, I know you have some very interesting thoughts. You have 10 minutes, and we are ready to listen to you. Thank you.
Thank you very much, Nishant. A pleasure and honor to be here today, and my sincere congratulations to PMJY, National Health Authority, for so much progress over the last 4 years. I was just very impressed this morning, and thank the panelists for some great presentations as well. So after 2 years of sitting at home with the COVID pandemic, I'm delighted to be back, and really my hat's off to you for the progress you've made over the past couple of years. So I've been asked in the few minutes that I have to talk about some of the global experience, particularly a couple of countries here in East Asia, Philippines and Indonesia, and then to talk about what are some of the lessons and ideas for India to reach universal health coverage. So let's start first with a look at East Asia, Indonesia and Philippines are both stuck at between 80 and 90% of coverage. Philippines has been at it for several decades. Indonesia has been at it for 7 or 8 years now, and it's not unusual. The Thai were stuck. Thailand was stuck at 70%. When I worked in Iran, they were stuck at around 70%. When you ask Suman Kwan tomorrow when he's here, how long did it take South Korea? He will tell you 29 years. If you talk to Japanese experts, they will tell you it took them 40 years. So being stuck is not unusual, and it's usually the missing middle. And we really see 4 or 5 obstacles globally, and not just in these 2 countries. First of all, it's paying the premium in a contributory scheme, and by far this is the most significant barrier. People in the middle are often living at the edge, and they enroll when they get sick as a result, and that creates adverse selection, and that creates risk pool deficits. So Indonesia and Philippines have both tried to minimize it by making it a fixed amount and not dependent on income measures. But I hear anecdotally, I talked to a taxi driver in a city in Indonesia. He's got his own company. He says, when I make money, I put it into new taxis, I put it into new people. I will join the health insurance organization when my wife and my kids get sick, and not before. So this is not an unusual sort of sentiment that you hear. Both countries have raised the poverty line over time and have done special things, like if you have a TB diagnosis in Indonesia, you're automatically covered, even though you haven't been covered before. In Indonesia, they've gone from about 80 million people to 120 million people just through general revenues and raising the poverty line, so that was quite significant. At the same time, 25% of the enrollment in Indonesia have stopped paying premiums during the COVID pandemic for reasons that we can guess. I think related, there's often a perceived value for money. Nishant mentioned the supply side and the demand side, and there's really very little supply side in many of the rural areas. So why pay premiums when the clinic is closed or the clinic is not stocked? In the Philippines, they've decided to expand the benefits package to include more primary care. That's great as a way of bringing people in. And they've also started looking at pro-health taxes, pro-health taxation, some very innovative programs, and started to think about moving some general revenues to cover this last remaining 10, 15%, depending on how you count it. So I think that we will see universal coverage in Philippines coming, but it will only be through the use of general revenues and less use and reliance on contributions. So that's the first point, paying premiums. The second point, identifying the unenrolled. Neither country knows who is still not enrolled. Indonesians are currently doing a series of focus group discussions to find out. They have previous surveys from the last couple of years and those surveys have found that ability to pay is a very significant issue. But there are barriers for enrollment, even if there's interest. For example, in Indonesia, you do need a birth certificate, and people in many rural areas do not have birth certificates, so they cannot join even if they want to. So premiums, who are the uninsured? A third area is information and education. Both countries find many people are unaware of the program, even now, after many years. They don't know how to enroll, or once they're enrolled, where to go, or who to contact, or even what's in the package. So here, I don't know of anything that has been done in either country that goes beyond what I've seen here in India. So there's not much to really add for people here. A fourth element, a fourth issue is convenience. Both countries have attempted to ease enrollment and payment through convenience stores, through ATMs, through mobile phones. How well have these programs worked? I haven't seen any evaluations of these programs. I don't know if they exist, but anecdotally, people seem to feel that these have really helped and that they have been good measures for enrollment. Final point, irregular income streams. So you can imagine a rural agricultural worker, they don't have steady income streams. And so a big issue in each country is how do you allow people to pay who are facing these irregular income streams? And they're both talking about it in each country, but I don't see any action to this point. So those are sort of the 1, 2, 3, 4, 5 issues that most countries face and are faced in Indonesia and the Philippines, and what they're doing about it or not doing about it. And Nishant, maybe a few points about what India could do going forward. I know we're running out of time, but I've come up thinking about what's going on in India. I've come up with really 10 points that you might consider. Point 1, you're the fastest growing economy in the world. I've learned that from I.J. Tandon, and that creates more fiscal space. That portends greater fiscal capacity being the amount of money going into the Treasury as a percentage of GDP. Now, of course, you have to convince the Ministry of Finance, even in these very difficult economic times, to put more money into the healthcare system. As a way to improve productivity, as a way to decrease poverty. You'll have to do that. But if you do that, with more funds, how do you spend it? And I would say funds, both new funds and even existing funds that might be going to supply side or line item budgets, should increasingly go into risk pools and prepayment schemes. This is a bit of a controversial point, but nevertheless, I would like to see that continue, whether it's new funds or existing funds. That brings me to point 2. As I said, some of the countries have been successful in raising the poverty line. If you have more funding that's going through a prepayment scheme, raise the poverty line for PMJY. You have 500 million now. Maybe you could raise that poverty line to include 600 million or even 700 million. This brings in the near poor and very quickly. Point 3, make coverage mandatory if you're going to go the health insurance route. Now, there's been some debate for many years in India and even today about whether we use insurance or not. I completely agree with the previous speaker that universal health care is not necessarily universal health insurance coverage. But if you're going to go that way, then make it mandatory. Don't make it voluntary. Voluntary means that you're going to have adverse selection and moral hazard, so you don't want to go that route. Point 4, well, I want to say that on point 3 as well, you really want to give them choice. If you're going to force them to buy insurance, then give them choice, and I'm delighted to see that there's also been some convergence of schemes, and we heard about that this morning with ESIC. Point 4, for people still above the poverty line but close to it, know what people are willing to pay and what they can afford to pay. And once you know this, perhaps you already know that, begin to subsidize the premiums for insurance. China, they had a nice matching fund, 50% from the national level, 30% from the state, 15% from the district, and the consumer paid 5%. And they got everybody in because of this heavy subsidy. The subsidy has to be relatively significant to work. It's not going to work if it's a relatively low amount, 30%, 40%, 50, even 50%, it may not work. Point 5, make it easy to enroll, create incentives to enroll. I like what's being done in Karnataka. I like what's being done in Maharashtra. You have a lot of good state experience here. Point 6, allow flexible payment arrangements, as we've just discussed with our neighbors, Indonesia and the Philippines. Point 7, create a minimum benefits package that is attractive and affordable as possible. Force every insurer to sell it, and as well as make sure they accept anyone at the door who's coming knocking. Point 8, build a supply side. Nishant has talked about that already. Very important. In Vietnam, premiums were almost zero, but nobody was enrolling because people in Vietnam said, well, there's no supply side. I'd rather spend the money on mobile phones, on rice, on clothing for my children, even cigarettes were more important to them than their premiums for health care. Point 9, allow people to switch plans every year and allow plans to choose contracts with providers public and private, which will open the market and help integrate the market. Encourage insurers and providers to integrate into managed care organizations as might occur naturally, or with incentives through public policy. And my last point, maybe my favorite point, is over the next 10 years, transform the National Health Authority into a National Health Board. A National Health Board that would oversee things like the benefit package, the standard benefit package across insurers, that would oversee prices and payments across insurers, that would oversee the IT system. You're already doing that. That's a great first step. Interoperability and standards. Develop the quality metrics by which you analyze and look at performance of every insurer, and certainly disseminate that information as that information becomes available. And I think Niti Aayog has already started that process. They've already started the ball rolling in terms of these league scores for states, and that's very impressive. So that's what I would like to see. Now, you have the fastest growing economy. You're going to have a bigger economy in 10 years than Germany has, so you should have a system that's at least as good as Germans have. And I think with your multi-payer system, that's the way you seem to be going, you can have a system that's at least as good or even better than the German model. So Nishant, sorry to take so long, but thank you very much.
Thank you, Jack, and thank you for outlining things very clearly with 10 points, what could be some pointers for India for going forward. So I wanted to thank all the panelists. It was excellent session, though we could not have too much time for question answers, but this was great. And just a logistic announcement that the lunch will be in Friendship Lounge after this session. So now I hand it over to Shalini Prasad ma'am for your final comments as chair of the session, and if there's something you wanted to highlight. I can add, if you want as chair, Okay, so chair wants to have 2 questions. Now, anybody who wants to ask any question to any panelist in particular or in general, please do ask question, raise your hand, and we will be very happy to take the question. Is there, yes, ma'am, please. But do we need a mic for her? Oh, yeah, actually, yes. I take back my words, you don't need mic.
Imagine the difficulty with which they are running the scheme. So I am coming from a state where there is plenty in the supply side, and how to match the resources is a real challenge for us. We have 36 government medical colleges and 28 private medical colleges. In addition, we have so many standalone corporate hospitals. But I would just add some points to the Maharashtra sir. What he said is government side, it's very difficult to add on the burden for again PMJV and other allied schemes, so that the burden on the government sector is added thing for the government doctors. But what I would like to say, Tamil Nadu is allowing private practice for the doctors as well. And we have added so many capital expenditures like cath labs, then again 1,000 dialysis machines. We have around so many linear accelerators and all the urology, nephrology, so many high-end equipments have been added. Again, we feel that this PMJY or whatever may be, it is an add-on to the existing, state government's resources. So in a way, if we are able to give or reduce the out-of-pocket expenditure for the people who step into your institution, for example, for dialysis, you need such a lot of consumables. Again, for a hip transplant, for a knee transplant, for a stent, and for all the high-end, drugs. And sir was our ASMD when I was in NHM. There is no support for the medical colleges. We don't have untied funds. We don't have Kayakalp additional funds. We don't have NQAS accreditation also. Now only we are stepping slowly into the NABH. So the only resource income which is available in the government medical colleges is the fund which is generated through the PMJY or the insurance. And we are returning back 72% of the total package cost to the medical college itself. Only 28% we are taking back to our state government corpus fund. And that also is again refunded to them for over and above 5 lakh packages, or some people who don't have insurance cards. So this 72% is a resource, a money which is available at the HOD, which is a free pool of money. They can say put so many additional staff nurses, cath lab technicians, dialysis technicians, whatever drug is nil stock in the TNMSC, immediately they can procure at the market, and all the consumables, 100% we assure that it is given free of cost to the public, only using this money. And I'm very proud to say that we were only 32% of the government share of the insurance when the scheme was started since 2012. And last year we have touched to 49%, which is the highest in the state record. So again, every 3 months, CM office is also periodically reviewing the scheme, considering the huge amount, 1,450 crores is the state government's budget for the scheme. So this we take it as a proxy indicator how the institution is functioning. We are having 10 neurosurgeons. What is the amount of insurance money you have, say, received in the institution? So see, this is a real tool which helps us to measure the performance of the institution as well. So definitely it's a very good way, and we also ensure that 100% free treatment is given for all the public with the insurance card and without insurance card. And next step, we are also starting pay awards across all the medical colleges so that the government employees insurance scheme is also empaneled, and also we can extend our services. Thank you, sir.
Thank you. So it was less of a question, more of a very important information. So from this side, Rohit, you have a question?
So you talked about the two important indicators for two important parameters for the universal health coverage, and that was in terms of the financial cover and in terms of the services. So where do we need to strike the balance? Like, you know, there is Meghalaya, which is providing OPD also under the insurance cover. And we also talked, and you talked about that out-of-pocket expenditure, that whether it is really like, we didn't have any survey as of now, but somehow we understand that yes, it has impacted the out-of-pocket. But the primary reason why out-of-pocket has not come, may not have drastically come, is because OPD and the drugs. So my question again, going back to my question, that where do you need to strike the balance in terms of the coverage of the services and the financial cover, like 5 lakh rupees cover is important, or it is the increasing more number of services to bring the out-of-pocket expenditure lower, and to maybe to increase the benefit of universal health coverage?
Thanks. So let me just break the two. I mean, in terms of the financial limit, 5 lakhs and all, I don't think there is a pressure to raise it, because if you look at the number of cases, you will have the data. I think less than 1% may be the ones who would be touching 5 lakhs, maybe not even 1%. So really no case for enhancing the ceiling, because families are not really touching the ceiling. Now, what you realize is almost, I mean, the last survey said 70% of our out-of-pocket expenditure is on outpatient care. Okay, so we still not, you know, with this PMJY, you're not really hitting. With the comprehensive primary health care through the health and wellness centers, you're trying to hit that part by trying to ensure the free drugs and diagnostics initiative. You're trying to hit at the out-of-pocket expenditure largely happening for the outpatient care. And that, I mean, 90% of cases can really be managed at the primary care level, and that is far more cost effective. So the reason why WHO, World Bank, everyone is pitching for comprehensive primary care as the cornerstone for moving towards universal health care is that it's cost effective. 90% of the health conditions, you don't even have to advance to a thing where you will again need very complicated procedures where it will cost you a lot of money. So really, I mean, the challenge is really in terms of operationalizing that comprehensive primary health care through health and wellness centers, and I mean, a whole lot of governance support, a whole lot of, you know, in terms of design of provider incentives, very clear treatment pathways, and good training and orientation, and then good IT mechanisms to enable integrated care. I mean, a whole lot of things have to happen, telemedicine, ensuring access to essential drugs, diagnostic, good grievance redressal systems, which would then really advance very fast or accelerate our progress towards universal health coverage. Not that PMJY is not doing a great thing. I mean, we realize that those who get hospitalized, they really need a large sums of money. But unless we really address the source, which will, we need to cut that source where people keep on getting seriously ill and reach at an advanced stage where they require costly treatments, we really will find it unsustainable. Thank you.
Sir. Thank you. So Pankaj, we said two, but there's an exception.
Sir. Sir, I'm Pankaj, sir. Sir, just a question to the panel as such. There's a problem which occurs when a person goes for treatment as such. If he doesn't go to a health and wellness center, he doesn't get the OPD facility, and before getting any surgery done, he needs to get a PAC investigation done. There's a big question mark that who will pay for that, because the package of IPD is only available in ABPMJ, and the OPDs are available in health and wellness center. Don't you, the panel will have just a thought about it, what should be done if that OPD facility should be available in the same hospital the person is visiting. For example, if he's going to a private hospital, he can give it free of cost because he is generating patients otherwise for IPD, as well as he's generating footfall in the hospital, which is giving different kind of incentive to the person. So this is a big issue, sir. The patient suffers a lot because he doesn't get the treatment and it costs a lot of out-of-pocket expenditure for the patient, sir.
Sudhakar, you want to answer?
Yeah. Regarding this depends on how you devise your contracts with the hospital. Like we have some learnings with our past experiences, and in Maharashtra we have agreement with all our hospitals which are supposed to mandatorily treat patients free for OPD as well as all the investigations prior to the pre-authorization, and that too for 90 days. Because there was a practice that hospitals used to get all the investigations done 15-20 days, a month before, and get the patient for the surgery later. But now we have this provision, and we check through the Arogya Mitras in the hospital whether this patient was presented in that hospital for last 90 days, and whatever expenditures were incurred, they will be refunded. So we need to devise a mechanism for that. And as far as other diagnostic expenditures is concerned, in Maharashtra we have MoHFW project where all investigations of 3 different buckets are done free of cost through our PHC. Now we are extending it to our sub-centers as well.
Thank you. Thank you. So, ma'am, there is one more hand. So with the permission of the chair, there's one more hand on the back or in the middle. And then we'll have to close because I think it may be better also to eat before the next session, so to get some more energy. Yes, please. Please introduce yourself also.
Good afternoon, everyone. Pleasure being here. Fabulous listening to all of you. My name is Dr. Anunay Jain. I represent Japaigo. My question to the panel is, we've been hearing about how value-based care can potentially play a role towards enhancing universal health coverage. When and do you think this is the right move for India, and when should we really be moving towards value-based care?
Value-based care, you know, we talk second, third generation of things. so if anyone... I think it's a very good thing to aspire for, and I think that what is being done with currently with PMJ and a lot of other things, there is scope to try towards that, but it's not easy. You know, you have to have all the building blocks and everything ready. So you want to add?
The capacities to move to a system of value-based care, or capacity to move to even things like, you know, health-based organizations and all. So I think these are stages of evolution in terms of our own capacities to manage health systems. So I think that's a direction to follow, certainly. Yes. Thank you.
Ma'am, last words to you, ma'am.
So since I've already given up my time for the question and answer, I think I'm just going to flag that this was a really interesting discussion, especially the presentations from the states, I think were, you know, because there's such a diverse country and we're doing so many different things, including, for example, we hear about Tamil Nadu, or we hear about, of course, the states which are on the dais. And everybody is trying different things. So I was just trying to calculate, maybe we've thrown up about 25, 30 different points today. And yeah, each of it, those are important, and going further to that question is, I think it is at the end of the day a question of prioritization and the direction in which we go, also the stepwise. So I hope this is really leading to, the discussion today will be leading to much further action and more discussion as well. So thank you.
Thank you, everyone. This was truly a very enlightening session. Thank you to our chairperson, panelists, and moderator for a very fruitful and engaging discussion today. NHA has also been very committed to research in universal healthcare, and we continuously work on various research publications with our partner organizations, both nationally as well as internationally. It is my pleasure today to announce the launch of 3 such reports with WHO, for which I would like to introduce Dr. Grace and ask her to come on stage. These reports are on the following topics: an assessment of trust and insurance models in ABPMJ implementation in 6 states, mainstreaming quality of care in empaneled hospitals under ABPMJ, and analyzing effectiveness of targeting in ABPMJ in India. Welcome, Dr. Grace. You can just... I would now request our chairperson, Ms. Shalini Prasad, to launch the reports with a click of the button. Thank you. Finally, we would like to end the session by presenting mementos to our esteemed panel. May I request moderator Dr. Nishant Jain to present the memento to Shalini Prasad ji. Now may I request Chairperson Shalini Prasad ji to present the mementos to our panelists, starting with Shri Dilip Kumar Kotia. Shri Manoj Jalani. Shri Sampat Kumar. Dr. Sudhakar Shinde. Dr. Jack Langenberner. To Dr. Nishant Jain. And finally, to Dr. Grace. Thank you for being a wonderful audience, and we request you all to proceed for lunch. For the panelists, please join us for lunch in Aud, and the rest of the delegates can join us for lunch in the lunch area outside. The next session begins at 2:30. Thank you. All the principal secretaries and ACS should join in Aud for lunch.